Welcome to Adapting Class. So today we're going to talk about mental health disorder. I'm going to take one patient and we're going to use that patient as a concept and go through each of the key mental health concepts you need to know for your NCLEX. We're going to talk about their disorder, pharmacology, medications, and nursing priorities. So let's walk through these cases and then we can use them to consolidate everything we need to know about mental health. I will be typing some of the information as usual. This is Adapting Class way of teaching. I think that's the best way. And so I'm going to present the case for you and then we'll walk through it. So we have a 32-year-old female, right? And the husband said the patient has not been sleeping for 3 days. So no sleep for 3 days. And what is the patient saying? They said they're going to do what? Start a business in 5 days. So how can you start a business in 5 days? Another thing the patient's been doing is what? Shopping all day online and no sleep. Patient heart rate is like 110 and the blood pressure is 140 over 88. What should be going on right now in your mind when you see this kind of case study? What do you think is going on? We're trying to use this information to go through mental health, all the concept. I'm trying to show you something. What do you think? What should be going on right now in your head as you try to figure out what's wrong with the patient? You can type your answers and think, and then let me know. A 32-year-old, 3 days, she's not been sleeping. She says she's going to start a business in 5 days. She's been shopping online all day and then for 3 days. And those are the blood pressure and the heart rate and other things. What do you think is going on with this patient? Let me know. But as you can see, this is a mental health. The most likely diagnosis that I can tell you is what? What do you think? The most likely one is somebody who has mania, right? This is a maniac disorder, right? Bipolar patient in mania. What else do you think the NCLEX will be giving you if this is the mania? They're not going to tell you, but they're going to give you signs and symptoms. So what should you be looking for? What other signs and symptoms should you be looking for in this patient? Of course, they have given us some of us. Decreased sleep. The patient is not sleeping, right? The patient is not sleeping, so decreased sleep. And spending spree. Patient is just spending money just like that. What else? Grandiosity. That you can see, she said she's going to start business in 5 days. That's what we call grandiosity, right? What other information would you want to know? What other assessment finding, which you can see in a patient with bipolar, right? You can have elevated moods or like a pressured speech. I see somebody type that, right? Pressured speech, what do you think? What else? Flight of ideas. That's another signs and symptoms associated with these bipolar patients. So flight of ideas. So these are all concepts. It's good to know, right? They're going to have poor judgment. And then they may have rigged behavior, right? But the most important thing you should know, this patient will self-neglect. This is the biggest. Don't forget about this. Self-neglect is big for these bipolar patients. So we've diagnosed the patient, 32-year-old, 3 days, no sleeping, want to start business in 5 days, been shopping, and we think in a maniac state with these kind of symptoms you should be expecting in that patient. So what is the NCLEX tips here? I want you to don't forget about it. NCLEX tips when it comes to mania disorder, there's a tip here. If you see high energy, always low judgment. They cannot do anything. So high energy is equal to low judgment in terms of their thinking. So they can think properly, and that's why they can spend money on all those information. That's why they do like that. So low judgment. That's the key thing about these people. And so your priority is what? Safety. Safety, safety, safety for these patients. Safety, number one for the nurse. So if you are the nurse, because this is what the NCLEX will take you. Now, you are the nurse. What kind of things are you going to implement when you're taking care of this patient? Let me know. You can type it in the comment section. Now, we want to implement some therapy for this patient in a hospital. We're taking care of this patient. What kind of therapy will you institute? Right? I already talked about safety, so we got to do that. What else would you expect the provider or the nursing care system to include of? And the number one, you already know, is what? Physical need. We got to provide some physical need as much as possible. What else? There's another important thing I don't want you to forget. It's about setting limit, right? You got to set limit because they never stop. They're not going to stop. These people, they will keep on going. And the environment has to be low stimulating. And there's one more in terms of therapy. If you have to institute the therapy, what kind of therapy? One-to-one therapy or group therapy? One-to-one therapy or group therapy? Which one? One-to-one therapy or group therapy? Very important. It has to be one-to-one until they're ready and they all fine before you can do group therapy, but usually one-to-one therapy. The nurse has to provide some nutrition. And the nutrition, like I said, is to provide their physical needs. So these physical needs that we got to provide here, very, very important. What kind of nutrition are you going to give to this patient? What do you call it? Finger food, right? Finger food. You should be able to identify, the NCLEX will give you medications or informations about finger food, and you'll be able to give them, pick one out of them, and you should be able to pick which one is a finger food, right? Finger food are something that is like high calorie as much as possible, right? You can give them high protein diet, right? Something they can take with them so that they can get all the energy that they have when this is going on. So this is the first patient, and I know you got it now. This is the first patient. This is what is going on with them. And this is the priority information the NCLEX will ask you. Of course, they're not going to be like that. You may have to take care of them. The next thing is going to happen is the doctor will say, well, we got to do pharmacology. There's a bunch of medications that you can use for these patients. Which one? Pharmacology. How do you treat them? Pharmacology, medication. What is the most common medication you know of that we can use to treat bipolar? It's lithium. But don't forget about other antiepileptics. Antiepileptics are also important, like valproic acid, like carbamazepine. They can also be used in a bipolar patient. Very, very important. The one you shouldn't forget is lithium. So that's the key. But what is the NCLEX going to ask you, right? What is the NCLEX is going to ask you? I don't want you to forget this. That's the key, right? This one is the key in terms of lithium. Don't forget it. They're going to ask you about the range. They're going to ask you about signs and symptoms. So they're going to ask you about the range of lithium. They're going to ask you about signs and symptoms. And then they're going to ask about toxicity, right? So you got to know them, what you see when it goes up and what is going to happen to the patient. So that's where we are. We are now on pharmacology, and we're talking about lithium. And we have to know the range. The most common one, always don't forget 1.5. Always, most bad medications, 1.5 is the key limit that are always used, like 1.5. Therefore, you should expect the range to be less than 1.5. So the range is 0.6. This is something I want you to know it. 1.6 to 0.6 to 1.2. And if it's greater than 1.5, it's not toxic. This is a toxic state, right? Are they going to ask you? They're going to ask you priority information. So priority information for toxicity is what? What are you looking for? What is your number one? Number one for lithium toxicity. This is crash course on mental health. We're going to walk through all the information that you need to know. What is number one toxicity for lithium? What do you think? Put that in the comments. Let me know. But what is this? What the NCLEX is exactly going to ask you, right? It's a GI symptoms. So these GI symptoms can be anything like nausea, right? They're vomiting. They have anorexia. They can all of this. They have diarrhea. These are all bad problems. So these are your priority information. You're looking for a patient who is on lithium and is having diarrhea, nausea, vomiting, or anorexia, right? Those are the key. Remember, there can be other symptoms, so don't get trapped. These are the traps, right? They're going to have tremor, right? And this tremor is like cause tremor. They're going to have confusion. These are another also issues associated with lithium. They can have ataxia, neurological problem. Even if you don't know, pick an answer choice that talk about neuro. They're going to have seizures. But what is the problem? I don't want this to happen. That is why these are the red flags. I don't want them to happen when I see them bad toxicity. So I'm looking forward GI symptoms as number one. Therefore, what do you do when you see this, or how do you prevent these toxicity? So now prevention. We know what lithium does. How is it going to prevent it cause this problem? How do you prevent it? Know this, okay? Know this. I'll put a yellow or maybe use different color, but these are, you may not see it, but this is very key. This is how we can prevent them, right? Teaching, this is the risk reduction questions you see in the NCLEX. Very important. Risk reduction. How do you prevent it? What kind of teaching do you give them? These something, if you have a pen or paper, I want you to write it. And what is that? They should avoid NSAIDs, right? They should avoid ACE inhibitor. We talk about it briefly. This is a crash course. They should avoid diuretics. Why? And then they should increase their fluid intake 2 to 3 liters, right, a day. And they should maintain their sodium normal. Why all these things? Because anything that affects your kidney, all of this affect your kidney, right? They affect your kidney. So it's a kidney problem. So if they are affecting your kidney, that's where the lithium is going to do its damage, then you shouldn't cause anything that can affect your kidney. NSAIDs affect your kidney. ACE inhibitors affect your kidney. Diuretic affect your kidney. In which ways? By decreasing fluid and affecting your sodium level. Therefore, this is what you teach lithium patient not to do that. This is everything you need to know about maniac disease associated with bipolar patient. Guess what? We're not done. Now, what happened to the patient? This patient came in later on, said, "Hey, doc, I'm doing fine. I'm doing fine. I've been good." Then weeks after being on medication, this is what they're saying. They came in, they said what? After weeks of mania episode, the patient crashes, right? It crashes and they tell you, "Hey, for 3 months, this is what I'm having. These are the signs and symptoms I'm having," right? The patient told you what? Patient cannot sleep. He's been sleeping for like 14 hours now. Now he's sleeping 14 hours. I cannot eat. I feel like I'm a failure. What do you think is going on with this patient? I've lost interest in my work. What do you think is now the patient who is maniac? It's been 3 months, be on medication. They said, well, I've been sleeping for 14 hours. I can't eat anymore. I'm a failure and I've lost interest in the things I do. This is what has happened to the patient. The patient is still now in what state? He's in a major depressive episode. And how do you can see what is happening to the patient now? The key here is this patient is acting different. So what would you do? This patient is acting different from what they were before. So they have something we call SIGICAP. That's what they're showing now. They're showing signs and symptoms of SIGICAP. And what is that? The S is what? Sleep issue. I want you to write this down. This is key. This is how you can remember depression, right? Their interest is going to change, right? And then that G is the guilt. They feel guilt is usually everything they feel guilty about it. Their energy usually go down. So that's the energy. And what is going to happen? Their concentration is affected. So this is concentration. The appetite usually can go up or down. So that's the thing. So appetite is up or down. So this is their appetite. So I'll put up and down. And then the P is the psychomotor agitation, which is usually they get mad so quickly, right? Psychomotor agitation. And of course, we all know what is the S is suicide. This is what the patient is portraying. She's showing signs of what? Depression. What is your number one thing now? What are you going to do? Based on what they told you, 12, 14 hours of sleep, no appetite, I'm a failure, and I've lost interest. What, if you see this question, what is the next thing you're going to ask? That's the number one. What is your number one? Next thing you're going to ask the patient. That's what NCLEX is going to ask you. Everything smell like depression. And therefore, what is the number one thing you're going to ask them? Suicide ideation, safety, right? And how do you assess this suicide? What kind of question are you going to ask? These are little things to connect together. Now we're connecting suicide to depression. What are the things you're going to ask the patient? Are you going to think about hurting yourself? So self-harm. And then what? You're going to injure somebody, other people, right? Or if you have a plan, you have a plan to do it. Are you thinking about hurting yourself? Are you going to hurt somebody, or you already have a plan? And then do you have any means to do that, to get the plan? So self-harm, what kind of plan are you going, do you have the means to do it? These are very, very important questions you have to ask the patient. Therefore, we know the patient is depressed. What are we going to do? Psychotherapy. Well, it's not going to work. We got to give them medication. What are you going to give them? SSRI. That's the common one they're going to give. We're going to give this patient. Now we're on pharmacology again. There is some certain pharmacology that if you're taking the NCLEX, you shouldn't forget. Number one is SSRI. Number two is MOIs. And then three, they have mental health medication, but we'll talk about it, antipsychotic. But for now, if they give you a patient with depression, most of the time it's going to be like SSRI. So know these guys, know the SSRI very much. Antidepressant, Very, very important. And the common one is like citrulline. Know this guy. It's very, very important. Write them down. If you then go learn about them. But I will talk about them briefly. Fluoxetine and paroxetine. Those are very common antidepressants we prescribe all the time. Guess what? The NCLEX is going to ask you specific things about them. So you don't even have to memorize them. What do you think they will ask you about this? Onset. Very important. It takes a while before it works. So it takes like 4 weeks. Tell the patient that. Their mood is going to change. Therefore, what should you prioritize when their mood change? Suicide. That's the thing. So you ask them if the mood change, what is going to happen? Suicide. Of course, these medication have sexual dysfunction. Don't worry about it. But there's one side effect you should never forget to teach the patient. What do you think? Anybody on what? SSRI, what is one thing you want to teach them? NCLEX will ask you, what is that? It's a serotonin what? Receptor uptake inhibitor. Therefore, you got to teach them about certain things to avoid. That means don't do anything that will increase your serotonin. Otherwise, you have what? Serotonin syndrome. You see, we're down talking about serotonin syndrome. What are the signs and symptoms of serotonin syndrome? What do you think? Signs and symptoms of serotonin syndrome. This is crash course of mental health. What are your signs and symptoms of serotonin syndrome? I call it everything goes up. Things goes up. And that is the key here. Things are going to go up. Therefore, all your vitals up. What do I mean by your vitals are up? List them. Your heart rate goes up, your respiratory rate go up, your temperature goes up, you sweat, right? You see how you can connect that. And then you may have GI symptoms, cluness. In addition to GI symptoms, you may have diarrhea, symptoms going up. You see, reflexes, what is going to do that? Go up. This is how you can connect the dot to learn serotonin syndrome. Therefore, they should avoid things that are serotonin. Otherwise, they will develop serotonin syndrome. Agitation, confusion. So if they give you a selected apply, assuming I give you a selected apply, right? And I say, oh, serotonin syndrome. Which of this is consistent with that? I give you heart rate down, right? I give you constipation, right? I give you blood pressure elevated. I say reflexes down, right? And I can tell you what else? I say another example, I will tell you maybe diarrhea, right? So this is what the NCLEX will ask you. They ask you which of this is associated with serotonin syndrome. And you can tell that we based on what I said here, serotonin syndrome, your symptoms goes up. This is going down. It can be heart rate going down. It can be serotonin syndrome. Constipation is going down. It can be serotonin syndrome. Blood pressure is elevated. Well, serotonin syndrome. Reflexes is going down. It can be serotonin syndrome. Diarrhea is an elevated symptoms. Your symptoms are going down. So you see how you can know that these are the signs and symptoms of serotonin syndrome. So the lady who was maniac now went to what? It became depressed. We put the patient on antidepressant, and the patient is what? Depressed. We talk about serotonin syndrome. What do you think I'm leading you to? Now we have to think about other things. She's moving through the progression, right? The same patient came to the hospital. She stopped taking her medication. Now stop taking meds. She's not taking her medication anymore. And what did she say? When you talk to her, she says, I'm hearing voices, right? I'm hearing voices. And he said, the voices never stop talking. He said, they're telling me things I don't want to hear. right? Now, what is the patient? And she's refusing to take her medication. She said you're going to planning to kill her. What has happened to that patient now? The same patient who was depressed stopped taking her medication, and now she's hearing voices. And so I'm hearing voices, and they're telling me all sort of things I can't tell you. She does not want to take her medication. She does not trust you. And then she said, you guys trying to kill her. What has happened to her? This is the key. She's hallucinating. And so you got to know the difference between hallucination. I want you to know this one. Hallucination versus delusion. Who can explain? You can type your answer down. What is the difference between an hallucination and what? Delusion. We're talking about mental health concept, and I'm going to walk you through all the key concepts. What is the difference? There's a one big difference between delusion and hallucination. What do you think? If you know it, you can put an answer in the comment. But this is what we call, one is a perception versus what? A fixed thought, right? So which one is a fixed thought? I really, really believe this is going to happen. And one is a perception. The way to know is perception is mostly sensory. So it's one of them is sensory, and it's all based on senses. So what do you think? Which one is mostly sensory perception, right? And that is hallucination. Hallucination is sensory. They can feel something is crawling. They can feel, I can see it. They feel like they can hear it. And that is hallucination. So this patient is hallucinating. He's refusing to take a medication, hearing their voices. And then they say, you're planning to kill. So a little bit paranoid. This is what we call acute psychosis. The patient is in acute psychosis. Well, what do you think the NCLEX is going to ask you? Don't forget this. And if you have a pen and paper, write this down. When you then you learn more. Check Adapt NCLEX have a bunch of mental health videos on it. They're going to ask you about positive and then negative symptoms of what? Schizophrenia. Because this patient is psychotic and patient has schizophrenia. Move from depression to schizophrenia, acute psychosis. How can you distinguish between what? A positive and a negative symptoms? There's one word. Who know it? If you know it, type it. And you can see how you don't have to memorize mental health, some of the things you can apply. The difference between a positive and negative symptoms associated with schizophrenia is what? The positive is what makes the diagnosis. So this is why we diagnose you. This is how. The negative is the depressive symptoms or catatonic symptoms. So this is the catatonic features. Therefore, based on what I've told you, if this is a depressive symptoms, then it's easy. I'm looking for things that will cause depression. That's all. That will be my negative symptoms. So if I put a negative symptoms here, like that. So negative, anything that look like depression, right? The fatigue, right? You don't want to eat, right? They sleeping too much. They lost interest in things. Those are all depressive symptoms. Catatonic features, right? Those are, they don't move. They stay at one place. They're very slow. Any signs and symptoms they give you, that is not positive in symptoms, is a negative symptoms. And what is the positive symptoms? These are very, very important, and that's how you can distinguish between them. And so I want you to write them down, right? Hallucination, right? They will have disorganized thought perception. Very, very important. They may have some delusion associated with it. So Pay attention to that. This delusional thought, disorganized, and a thought perception. The thought perception is like they may have in leukemia, other symptoms. We're not going to go there. But these are the three. If you know them, then you can distinguish between the negative symptoms. So this is what these patients have. What do you want to do? More information about negative is that they may have flat affect, right? They can have flat affect, apathy, that like same thing I talk about, allogia, all those symptoms, they will be withdrawal from society. This is the key aspect. So watch for that when you see a case study and they go through all this thing. Right. Now, there's a thing NCLEX will ask you. It's about how do you take care of this patient? If the patient will tell you, look, the CI is after me, how will you respond? This is classic NCLEX question. Very, very important. Notice I have a YouTube short video. I talk about it, hallucination, how to communicate with these people. The CIA is after me. What would you tell the patient? Oh, there's no CIA, go away. Or what, they are not real. No, you acknowledge their hallucination thought. You acknowledge it, okay? But you don't reinforce it. So no reinforcement, right? You can say, I know you're hearing these voices. You feel like the CIA is after you. It's very frightening. But here in the hospital, you're safe, right? That's a good answer choice. So when you pick in an answer choice, make sure you are not reinforcing, you acknowledge it, and then you bring them to reality. This is the key, reality. This, I want you to write this down. This is the key NCLEX concept. You acknowledge it, you don't reinforce it, and you bring it to reality. This is mental health, pharmacology, and psychotic issue that you should pay attention to because you're going to manage this patient. This is how you manage hallucination patient. You acknowledge it, you don't reinforce it, but then you bring them to reality. So that's how you answer it. That this may feel really bad to you, but that's not here. You safe. Nothing is going on here. So you got to provide the same therapy you provide what? The maniac patient, same thing, your intervention. Very important how to deal with this patient. Same thing, you got to provide some physical needs. So safety for this patient as much as possible. You got to decrease stimulation as much as possible. Once again, one-to-one therapy, okay? One-to-one, not group therapy. Don't pick group therapy, right? You got to set boundaries. So you got to set limits, right? And then they need some medication. Of course, you can't run away from pharmacology. I did some pharmacology series. You can watch them, antipsychotic. You will know everything about them. This patient need antipsychotic. Which one are you going to choose? Which one are you going to choose? Before that, there's one issue about hallucination. If they tell you that they hearing things about people, if they tell you about hallucination and they can hear things, you want to find the content about what they're hearing. But if they feel it, they can see. You don't need to find the content. Finding the content means asking them specifically what are they hearing. But if they say they can see, it's okay. But if they say they can hear, ask them, what are you hearing? It's not reinforcement. You're trying to figure out that you're not going to kill somebody. That's the difference between all the other hallucinations. There's different kind of hallucination. There's the hearing, right? Because it's all sensory. And there's a perception of touch and feel and see. By hearing, find the content. Now, let's go back to our pharmacology. What medication will you choose? There's two types. It's antipsychotic, right? That's all we got to give them. That's what we have. It's the first generation and the second generation. The NCLEX is going to ask you. So Be ready to answer them. Know them as much as possible. I want you to know them. Second and first generation antipsychotic. A few example is this. First generation, this one is the standard, right? Aripiprazole. Everybody know about it. Well, I want you to know something else. Maybe promazine or fluphenazine, right? There's few of them, right? These are all bad antipsychotic you should know about. Then the second generation is usually, these are the classic one, right? Risperidone is the prototype. So the NCLEX will ask you this, or olanzapine, or clozapine. But there's a bunch of them. These are common ones, right? They have a lot of side effects, bunch of side effects, but you got to teach the patient. The common one are what? They may have, you become orthostatic, right? That's fine. Don't worry about it. They may put it in the question. Don't pick it. No, they may have anticholinergic effect. Don't worry about this one, right? This is not a problem. They may have weight gain issue. Don't look at it. Hyperlipidemia. Don't look at it. And it's the reason why I'm typing them. They may have sedation. Don't pick it. These are all trap. They are not important. You want to worry about EPS and NMS. These is the two biggie, right? Extrapyramidal syndrome or symptoms, and then neuroleptic malignant syndrome. These are the one you worry about because they are dangerous. So I'm going to talk about them quickly. I will show you how to identify them. And you see that they are straightforward. EPS, just write down adapt. If you watch adapt in class, always don't forget. When you see EPS, write adapt, right? And what is A? Acute dystonia. That's all. This is acute dystonia. A is akathisia. You see, you got it. This is the way you can remember them by remembering this channel. Akathisia. And the P is Parkinsonism. They look like they have Parkinson. You see how I follow the same thing. And the last one is what? T is tardive dyskinesia. So we're going through the mental health. We saw a patient who was what? He was a maniac, developed depression. We treated him, both maniac and depression, become psychotic. Now we're treating them with psychotic. They're developing side effect, which is what? Extrapyramidal side effect versus the NMS. And then I say EPS is what? Adapt. And the way to remember them is acute dystonia, akathisia, Parkinsonism, and tardive dyskinesia. Don't let the NCLEX trap you. Look, I'm going to summarize it for you. If you need detail, check my website, my YouTube channel, you find them. But acute dystonia is the earliest one, very, very common. It's mostly, they will tell you muscle spasm. It's not the same thing as NMS, where they have muscle rigidity. Muscle spasm is not the same as rigidity. So this one is spasm, acute dystonia, and that's what you pick. Akathisia means they can't stay still. That's all. So this is akathisia. They can't stay still. That's all. These patients can't stay still. They're walking around, they just like, they sweaty, they can't do anything. Parkinsonism, they look like Parkinson patient. Once again, please, don't let, this is the trap. A Parkinson patient will have muscle rigidity. They may have rigidity, but it's not the same. They have cork rolling. It's not the same. And the big one is what? Drooling. When you see them write down drooling, a patient taking what? Antipsychotic and they're drooling. And you pick as a priority, that's not airway. It's hypersalivation. Hypersalivation. The medication will make you salivate. So that's why they have drooling. So it's an expected finding. Please don't pick it. Anybody giving antipsychotic, especially first or second generation, and they're drilling, they're having Parkinsonism. Don't worry about it. That is expected finding if there's any other things over there. So Parkinsonism and TD, you know what they do? They roll their tongue, they lip smack, they smile, and they're basically laughing some way that, they will show you their tongue. This is all associated with EPS. What is the treatment? If you never heard it before, I want you to write this down. Treatment of what? EPS. It's so simple, straightforward. Give them anticholinergic. Easy. Even you can give them diphenhydramine, anticholinergic. If the answer choice is anticholinergic, or you decrease the dose, but number one is an anticholinergic. Cogentin, yeah, one of them. This is one of the medication, bromocriptine or benztropine is an anticholinergic. You've heard it before. It looked like atropine, right? Anticholinergic. So the treatment for EPS is an anticholinergic, and that's what you give it to them. Crash course going through mental health. Now, if they gave you something else, all of a sudden, the patient temperature is up, right? Temperature is up. They have muscle rigidity. That is different issue. Now we have a muscle rigidity. And the autonomic nervous system is ramped up. So the autonomic nervous system is up. This is what? And they have fever. The temperature is what we talk about. And this is what we call NMS. This is dangerous. This is the dangerous one. It's more dangerous. They will have rigidity. They have confusion. This one, you got to stop the medication, right? You got to take them to the ICU. They will need an IV fluid, right? And they will need the same thing, medication to stop it. The medication is dantrolene. So this is the easy medication you can give to the patient, administer. You can also give them other things, but you have to hold it. Hold the medication first. Safety is the key, and then you can treat it. This is what I want you to pay attention to. So far, we're taking care of the patient. Guess what? We may be losing the battle, right? We may be losing the battle. The patient came in a month later, and she said what? All right, this is what is happening. She presented to the emergency room, and she was like what? Palpitation. She's having shortness of breath. She's trembling. And she feel like she's having heart attack. Same patient. And then they did the EKG. It's normal. What do you think is happening to the patient now? What is happening to the patient? Same patient came to the emergency room, now having heart palpitation, shortness of breath, trembling, and feel like she's having heart attack. They did the EKG. Everything is fine. Somebody who is psychotic came in and is showing these signs. What mental health diagnosis do you think this patient is now showing? What disorder is that? Palpitation, shortness of breath, trembling. I feel like I'm having an heart attack, but nothing was fine. What is the wrong with this patient? This is a panic attack. This patient is showing signs and symptoms of panic attack. NCLEX love this. Please write it down. This is NCLEX favorite because it's common. It's very, very common. Nurse intervention. What do you do when you see a patient who is having panic attack? You see it all over in QBank when you're doing questions. What do you do? What do you do? Number one, I want you to don't say anything. Don't say anything. Stay with the patient and just listen. Listen, listen, listen until they stop talking. But don't do anything. You speak calmly if you got to speak. But let them do their thing, okay? Let them do their thing and keep on talking. And you use very simple sentences as much as possible because they can't hear anything. They panicking, and panicking. They'll be slow, deep breath. You teach them breathing techniques. So slow, deep breath, right? As much as possible so that they can calm down. And then you tell them to calm down, but you got to reduce stimulation. You can't do anything. This is something you will see all the time in the NCLEX. They want to test your test-taking strategy. Patients having panicking, feel like they're about to die. You should not intervene. Just let them be and then be quiet and provide safety. But don't leave them alone and stay with them. That's the key. So this patient, what do you think? What are you going to do with this patient? Finally, the doctor said, okay, well, I don't know. We got to treat you with something. So we give you benzos, right? This patient was given benzos. Benzodiazepine is because it lower the anxiety. What are the teaching you're going to provide for this patient? There's one thing you got to tell them, right? He can't drink, no alcohol, right? If you have female, well, it's not good in pregnancy. I'm giving you a bunch of pharmacology so that you can use it to answer questions. Very, very important. You can't drive with it, right? No driving. Even though we have a bus, we have another anxiolytic that you can take to drive with it, right? Buspirone, but not this one. That's the bus. This one, benzodiazepine, you can do that. So this is the very, very important safety teaching you have to provide to the patient when they're getting these kind of medications. And you have to tell them, there's certain things you have to tell them. What else do you tell them? Withdrawal, okay? Withdrawal symptoms. You can't stop it right away. Otherwise, we get into trouble. The medication, what? It can start right away, can do its effect. That's why you shouldn't stop it. You got to taper it slowly. All these things you have to tell them so that they don't come back to the emergency room and then we get into trouble. Otherwise, if they stop it right away, they're going to have seizures. So that's the key. If you do that, we are in trouble. That's why you tell them, number one priority, somebody taking benzodiazepine, they stop the medication. This is what you tell them. They're going to go into seizures. Now you see how all the information connect, pharmacology, everything makes sense, right? Now, the patient was admitted to the hospital, right? Was admitted to the hospital back. Now, we have the same patient, right? He was admitted to the hospital. She's having tremor. She's sweaty, right? And then she said the last time she drank was 8 hours ago, alcohol. And she's not had alcohol after that. But she's been taking her medication. Sweaty, tremor, her blood pressure is a little bit slightly elevated. What do you think is going on? She says she drinks every night, but it's been 8 hours. I've not had anything. And now these are the symptoms. Alcohol withdrawal is NCLEX favorite. Please know them. Those who've taken these exams before, they've told me multiple times. Alcohol withdrawal. So I want you to know the first 12 hours, you're going to have anxiety-related symptoms. Write this down. Okay, anxiety, tremor, and anxiety. After that, up to 24 hours, 12 to 24 hours, you're going to have hallucination. This is when they start seeing Jesus, right? This is the problem. Yeah, this is the things they see, things they don't want to see. Hallucination. Then up to 48 hours, this is when they have seizures. And then 72 hours, they go TD, delirium tremor. This is the easy way to remember this. So when they give you a question, you know what to do. This is a easy way for me to remember that that's the way 12, 24, 48, and this thing. That's the way. What is going to happen to these patients? So anybody who drinks alcohol and they stop drinking every day and they stop drinking as the time goes by, this is what is going to happen to them. Okay. And then you have to know how to manage them. How do you manage them? I'm trying to give you all the things that I'm showing you is a trick, showing you where you should focus on when you're studying, right? I want you to focus on these areas. You can't learn everything, but these are little concepts. If you put it together, you can see that you know everything about mental health. And that's what people are afraid of. Number one thing is about seizures. So we don't want them to get seizures. The alcohol, because it's a downer. If you stop it abruptly, you go into seizures. So that's what you tell them. We got to treat them so that they don't develop seizures. What medication will you give them? What do you think? What medication? Somebody who is having alcohol withdrawal, they come into the hospital. We want to prevent seizures. What medication will you give it to that patient? What do you think? It's the same thing we give for anxiety patients. So they get benzos, right? Any of the benzos is fine. But the one that they use mostly is chloroperoxams. One of the benzos is a chlorodiazepine. That's the most common one that they use, right? That's the thing. You got to hydrate them, right? You heard about banana bag, and the banana bag, it contains fluid and certain things. It contains something in it. You will see it in the NCLEX. If you see it in the case study, it will be there. It's thiamine. Why do we give them thiamine? Think about it. It's a B1. This is a vitamin B1. They also need some glucose, right? You have to know the order which you give them, right? And then you got to monitor their vitals. These are the things you do about alcohol withdrawal. These are the check mark, right? They get thiamine, they get glucose, they get vitamin, benzos, and everything. But before you give the thiamine, you got to make sure there's a glucose available before you give them the thiamine. All these things very, very important. So what is the things you have to do in this patient? And this is what. So timing before you give them glucose, very, very important. If you give them glucose first, they develop what? Wernicke encephalopathy. I got to emphasize again. So very important. This is, I don't want you to forget, NCLEX will ask you. Okay, before you give them glucose energy, you have to give them timing, right? So timing, write this down. If you have a pen and paper, this before glucose. Otherwise, we get Wernicke encephalopathy. Wernicke encephalopathy. And I can take you to neuro right now. There's two types of encephalopathy, or encephalopathy, stroke, right? That can affect the Wernicke area and the Broca area. One person will talk too much, but it doesn't make sense. The other one doesn't talk, right? That's the Wernicke. They cannot, they have receptive issue, receptive aphasia. They don't know what you're talking about. They can't hear you. They can hear you, but they can't make sense out of it. So because they don't want you to know that they can't understand what you're talking about, they start to confabulate. They mix things up, right? Braca person, they can hear you, but they can't talk, right? So they're frustrated. Easy way to remember these two areas of the brain when you see Wernicke aphasia and a Broca aphasia. But in alcohol, this is what happens. You give them timing before glucose. So you see where you led this patient to? Alcohol withdrawal. Remember to treat it with what? Benzos before they get into trouble. So we saw this patient, antipsychotic, we treated, came back, benzo withdrawal, and then now having alcohol withdrawal. And we've tried to save this patient as much as possible. What else do you think mental health is going to ask you? There's one thing that they can lead you to, right? High yield from information of mental health. We've done psychosis, we've done NMS, panic attack, benzos withdrawal, alcohol. Well, there's a few things they may ask you. And then I call it the triple Ds, right? Don't forget it, okay? Delirium, depression, and what? Dementia. Know the difference. Write it down. Know the difference between these three concepts, right? I want you to know that I'm really, really want you to remember them because this is key. You will see them, whether you like it or not. There is an easy way to remember them. Acute problem. Patient is fine. All of a sudden, is crazy. Is what? Delirium. That's the one. So that's the one easy to remember, right? But if they wax and wane, right, back and forth, yeah, it's mostly dementia. They forget about things back and forth, right? And then if they are in between, it's mostly depression. But there's no change in sensorium in any of them. That means the key thing is delirium is sudden onset. Dementia and depression is not sudden. It's just a gradual onset. Delirium is reversible, right? Reversible. Dementia and depression is not reversible, right? Delirium is mostly caused by infection, medication, electrolyte, something acute. If you take it away, it will be fine. Dementia and depression is not, right? This is how you can, and then a loss of consciousness is key. This is LOC. Always watch for that. And the sensorium, right? Delirium will lose that. Dementia and depression, they will still have it. Hallucination. Delirium has hallucination. Dementia does not. And depression does not. These three things, put them together and learn them together as much as possible. So I have a mnemonic. I always sometimes, this is the way I remember it. Delirium, I call it what? Something fast and fixed, right? It can and it can be fixed. Dementia is very slow and steady, right? That's how you can and steady. One is fast and fixed. They're very fast, they happen, and you can fix it right away. It's fixable. If you take the infection away, it's fine. If you take the problem away, it's fine. That's how you can remember the difference between them. Now, what is the nursing priority? How do you treat this patient? Know that because you got to, there's a big difference between them. Nursing teaching or treatment is what? Take away the offending agent for delirium, right? You take away the infection, you treat them, you give them medication, and then you reorient them. Orientation and safety, because they try and get out of bed and they will fall, and provide calm environment. Those are the four things I want you to, if you see a case study or question, is what? Give them their medication, reorient, okay, safety issue, and quiet, and then less stimulation. So calm environment as much as possible. It's different from dementia patient. They have a memory problem. So day two is validating their feeling. I want you to remember this. Validate their feeling. Otherwise, they get frustrated, right? Like you babysit them, right? Validate them. Acknowledge whatever is going on, the deficit in their thinking. And then what you do, don't change things too fast. Retune is very, very important. A lot of people have had Alzheimer's questions, and this is how they trap them. You got to, every time you see Alzheimer's question, don't rush. Think about it. This is dementia. I got to validate whatever is going on. I got to make sure there's a consistency so that they don't get confused easily. Retune as much as possible. And the other one is easy for you to pick a wrong answer is this. You think it's not true, but it is true. What do you think? If you know what I'm talking about. is very, very important when it comes to dementia. Is this one. Independence. You have to promote independency. So when you see questions like that, I'll pick it. Always look for that. If it's there, it's true for dementia. Always promote independency. So as much as possible, so that they know that you are not babysit them in terms of ADLs. If they cannot, yeah, then you do it for them, but don't do everything. Independence with ADL is promotion. Is good to ensure that they are okay. Whatever deficit they have is not there. Alzheimer's questions on the NCLEX are hard because of these concepts. I want you to write them down and use them to answer questions. Validate their feelings. Make sure everything is with you. Promote what? Independence, and ensure day and light circadian is kept. Don't put them in the dark. When it's night, light off. That's the answer choice I want you to pick. Okay, if there's a clock there, arrange them. This is the key. Okay, you never argue with them either. If you argue with them, you're making them more confused and they get into trouble. So what do you think? A patient came into the emergency room. She's 82 years old. 82 years old, right? Came in. All of a sudden, she's confused, right? She's restless and disoriented, right? What do you do first? First thing you're going to do. What are you going to do? 82-year-old. If I see this question in NCLEX, she's 82. All of a sudden, she came into the emergency room. She's confused. She's restless, and disoriented, right? I know this is what? Classic delirium. There's some infection there. Either you check their pneumonia, they may have UTI, but this is number one thing is infection in this patient. So ankle strap, don't reorient a patient that is delirium. Always safety first. Find the cause of it. Don't reorient. Even though it's disoriented, the problem is confusion, disorientation, and restlessness. This is sepsis. So figure out what you need to do with them. Before we end, sometimes they will take you here. There's a legal thing they will ask you in terms of mental health, right? There's a legal, ethical issue. I made a video recently, 2 days ago. I want you to check it out. It's illegal how to address legal issues because they can be tricky. That is a way you can master them. And you know this ethical principle already. I don't have to bore you, but we got to go there. We have autonomy, right? You have beneficence, right? And then what do we have? We have non-morphism, right? These are ethical principles. You know them. We have justice. We have veracity. And then the last one is fidelity. Know the difference. Know how to connect them. When they ask you a question, you know what to do with them. What do you think? I know you guys got it. How would you know which one is which? Which one is which one? We know autonomy. It's right to choose. I can choose anything I want. I have the option to refuse treatment, right? How about beneficence? What do you think? It's doing good for the patient, right? That's what we're doing. It's different, and then is the opposite is you doing harm, right? Do no harm. So we don't want to cause any harm to the patient, but we have to do good. Justice is fairness. We all have to be treated fair, equal opportunity to all. And the veracity is what? Truth telling. You're telling the truth, right? You're being, and then it's different from keeping your promise, right? The example is like you give a wrong medication to a patient, and you went to the patient and you tell the patient that, hey, sorry, I give you a wrong medication. That is veracity. You're you're telling the truth. But when you tell them, I'm going to come back 20 minutes, and give you your medication, and it's been 40 minutes, you've not shown up, you violate fidelity, right? That means you're not keeping your promise that you should be back in 20 minutes. This is mental health, ethical aspect of it. I want you to know them carefully because they are ethical, simple, easy way to mix in the anchor. You lose points here. I don't want you to lose points. That's why I made that video, the ethical principles of medicine, nursing care, right? So don't lose points in this area. If a client refuses treatment, what do? Respect autonomy. That guy. If you see a nurse lie to reduce stress, what is they violating? They lie to reduce the stress, right? They're lying about something. Veracity. This is the way you should learn it. They're not telling the truth. If you make a promise and you do not keep it, you violate fidelity. That's the way they'll ask you the question. So these are a common scenario you will see on the NCLEX. And so pay attention. Now, let me validate your thinking and see if we got it. Client refuse blood. What are you going to do? Type your answers down. Let's see. Student nurse post, let me see, information online. Student nurse, they post patient information online. What have they done? Then the third one, let's see. The nurse, they gave medication without consent. What do you think? Client want to leave AMA against medical advice. What do? These are scenarios NCLEX may ask you. If I refuse blood, what am I going to do? If you post somebody information online, the patient without their consent, what have you done? Right? If you give a medication to the patient without the patient saying, I will take it, what is happening to the patient? What have you done? And if the client is about to leave AMA, what do you do? What do you do? What do you do in this situation? If they said they want to refuse blood, they have autonomy. They can do whatever they want. If you post information on somebody online without their consent, that's HIPAA violation. You breached, right? Confidentiality. If the nurse give a medication without a consent, that is a battery. You touch the patient without getting a consent. You have not assaulted them, that's battery. You went to that stage. And if the client want to leave AMA, what do? You explain to them the risks associated with it. You document their refusal, and then you let the doctor know. Once again, patient said, I want to leave the hospital. Don't hold them down. You get you into trouble by putting them in seclusion. Don't hold them down. Just said, okay, if you're going to leave, this is what is going to happen to you. If they said fine, you let them sign whatever document they need, document it, and then let the doctor know. This is the process you should follow when you see these ethical questions. Now, we have gone through all the stages. We have done everything. Now, what do you want to do with this patient? Sometimes we can delegate information about how to take care of them. Remember, the RN is doing most of the assessment and evaluation and treatment. Then the UAP basically deal with the ADLs. And then the LPN reinforce those teachings. So these apply even in the mental health situation. So delegation is also part of the mental health because these are patients that you take responsibility. What the things can you delegate to a LPN and UAP? Because there's a safety issue. You are responsible. I want you to write it down. When you see a delegation on ethics, remember, delegation tied directly to ethical safety, and you are responsible for what you delegate. If you delegate anything to the LPN, you're still responsible. If you delegate it to the UAP, you're still responsible for that. So there's things you can do and then things you cannot do. This is adapting class. We've gone through mental health from the beginning. What is that? We talk about a patient who is maniac. We give them medication, lithium. They develop depression. We give them SSRI. They develop serotonin syndrome. We provide some teaching. They came back, they have what? Psychosis. We differentiate between hallucination and delusion. We talk about positive and negative symptoms, how to recognize them. We talk about how to treat this patient in terms of a nursing care, that you acknowledge their feeling, you don't reinforce it, and you bring them reality. If they're talking about auditory hallucination or command hallucination, what do? You find the content of that. That is the key. And if you're treating them, they have two things that will happen to them. They can develop NMS and an EPS. NMS is a bad one. What is that? Temperature, everything goes up. They have muscle rigidity, the blood pressure goes up, they're about to die. All you need to do is stop the medication, give them what? Bromocriptine or dantrolene. If they develop EPS, you have what? Acute dystonia, akathisia, Parkinsonism, and tardive dyskinesia. We talk about what each one of them, and the medication you use is what? Anticholinergic. And then what do? This patient came back with a panic attack. How to treat a panic attack in emergency room. We talk about it. When you have to treat them with anxiolytic or anxiolytic like benzos, you know what kind of teaching you need to provide them. If they are female, you know what kind of teaching and how they should take it and when not to take it. They shouldn't drink, but if they drink, they shouldn't stop. If they stop, they go into withdrawal. How to treat alcohol withdrawal, and what are the priority for alcohol withdrawal, and how do you manage alcohol withdrawal in a hospital? Hydration, preventing seizures, giving them timing, glucose, and then monitoring them. And then, what do you think? Ethical principles you need to know when you're taking care of these patients. There is a risk associated with them. There's so many things associated with them, but you got to put it together. This is mental health. This simple 1 hour crash course. Just giving you some of the key. If there's areas you think you're lacking, I will focus on that. But this is the whole concept of mental health. Don't separate it, let them make sense, and then you can see that you master the content. This is Adapt class. Thank you for watching. Thank you for joining us. If you like this video, subscribe to Adapt class for more and put a comment there. I may have to edit this video multiple times before I can release it. So if you don't see it, but sometimes YouTube will be updating it. But thank you for joining us. I also put we have on demand that we have a you can do adaptive test. I put it on our post area community chat. You can take a look at it and take the test if you're ready to take the exams. It's a practice test, adaptive test to see your standard and the areas that you're having problem, you can master it. Take care of yourself and good luck in your exams.